If I could ask everybody to take your seats, and we'll get started with the second portion of ICD-10. So it's great to have such a wonderful turnout, and now as we enter into the discussion of ICD-10, I wanted to give credit that I didn't give in the beginning. This is a combined meeting of the Oregon Association of Orthopedic Surgeons and the Oregon Association of Orthopedic Executives. With OAOS, I'd like to give particular credit to Nan Heim and Diane Mayer and Jill, who really are the energy and the force of organizing and coordinating, and I get to stand here and speak about what all we've done, and they are the energy and the force behind that. And then with the Oregon Association of Orthopedic Executives specific, thank you to Jessica Gibson, Angela Fix, Laura Giles, and Paige Lennison for all of their efforts to bring this together so that we can try and understand more about ICD-10. Dr. Nichols will be speaking next. He's an orthopedic surgeon, not currently practicing orthopedics, but his full-time activities now are with Health Data Consulting, his firm, and we are looking to him to give us insights into what is on the road ahead in October. Dr. Nichols.
Great. Can everyone hear me? Great. Thank you. Well, I can tell you that if anyone had told me 20 years ago that I would be standing up here talking to a bunch of my colleagues about ICD-10, or if they'd even asked my office manager I'd be doing this, it would be unbelievable. My office manager, never in your life, right? Because I always thought ICD codes and coding in general was something to be done in the back office, that it really had very little to do with me, and I really wasn't that interested in it. Now, I am a data geek at heart. As a matter of fact, I have a condition for which there is no code, which I know there are a few. HCD-OCD. Has anyone ever heard of that? It's healthcare data obsessive compulsive disorder. And I think we may have a couple of people here that may have a little bit of that disorder also. But basically, I became extremely interested in healthcare data. And healthcare data is a very powerful tool to improve healthcare, but also a very powerful tool to be on the controlling side of healthcare. And what we're seeing today is we're seeing this huge evolution towards a data-driven environment in healthcare. I think we heard Dr. Tugg earlier say healthcare is under fire because it's just too costly. And we're just a small part of that cost, but nonetheless, we're part of the cost. And so we keep telling people that we have a lot of value, but frankly, as was stated, in God we trust, everyone else bring data. I think what we're going to see is that data is becoming progressively more and more important in terms of the success of healthcare, and to a large extent in terms of how our patients are going to get good health care ultimately. So I'm very much into health data. I taught a course at the University of Washington for 3 years to HIM folks on disease concepts. Been very interested in the whole idea of informatics, medical concepts as they relate to data and how we use them. Now, I never thought ICD codes really fit into that equation, but about 6 years ago, I was a medical director of a company called VIPS in Baltimore. We do a lot of systems development for Medicare. We actually had developed the fraud, waste, and abuse systems. We developed quality systems for New York Quality Alliance and Massachusetts Health Quality Partners, so we're deep into data. And they assigned me ICD-10. They said, you're the medical director, you're in charge of ICD-10. And I thought I'd been punished. But I did it, and I got into it, and I realized this is the biggest change to happen and the definition of the patient health condition in data in decades. We haven't seen anything. We've been with ICD-10 for 30 years. We've been sort of limping along. We said that it defines the patient condition, but really in use it doesn't do that very well. So we're moving to this new thing called ICD-10. Now I can tell you for sure that there's plenty to love and hate about ICD-10. There is no perfect standard. However, I do think it's important, and it's important to understand it, and it will be a challenge, particularly in musculoskeletal care. The #1 hit for ICD-10 is musculoskeletal care, almost 50% of the codes. All right, so we're going to talk about this data-driven healthcare environment because I think it's important to put this in perspective to understand what we're dealing with. If we talk about healthcare data, and like I said, I've been a data geek for many years, EDI systems, design data models, and there's 4 basic cornerstones of healthcare. There's the information about the patient, information about the provider, information about the conditions that is being treated, and the services that are done to improve or maintain that condition. So those are the cornerstone, and you'll see that ICD codes fit prominently into the condition, and at least on the hospital side, they fit into the definition of the procedures done in an inpatient setting. Now, CPT, all of those other codes are still used in the outpatient setting, but on the inpatient side, the definition is through what's called the ICD-10 PCS codes, the inpatient procedure codes. So, as Dr. Tug mentioned very well, we're seeing huge changes. This whole idea of bundled payments, pulling everything together, that when bundled, unfortunately, are now being driven not by physicians, are being driven by hospitals and other entities, right, who are going to bundle these things and then distribute the dollars, which puts us in a very difficult place as physicians because now we have to go and claim our piece of it, which is a challenge. But certainly CMS believes that before they'd even finish their project, that bundled payments were the way to go and moving very rapidly in that direction. Here, just this last January, Health and Human Services came out and said, we set specific goals for movement to a new payment methodology, or several different payment methodologies, that are related more on aligning payment with value and less on services. This is the first time they actually set specific goals. 30% of payments by 2016, 50% by the end of 2018. That's for inpatient, outpatient, professional, everything. On the hospital side, even more aggressive. 85% made through programs that include hospital-based, value-based purchasing, 90% 2 years later. And the belief is that Medicare spending could be reduced by $417 million, or was reduced by that amount in 2011, and they're anticipating progressively more. So there is clearly a belief out there that we're going to be moving to a new payment methodology that's driven less on what we do and more on what the patient's condition is. It's a shift. It used to be those codes were just for informational purposes. Now they're driving payment. Just as an example of this, I sat on a committee called WEDI, the Work Group for Electronic Data Interchange, and one of the things we did one year is we brought in people from around the world, 3 or 4 different countries at least, Australia, Canada, South Africa, and they were on a panel and we asked them what they learned about ICD-10. So they told us, one of the big things they told us is you can't crosswalk your way out of this, right? We all sort of knew that. But we also asked them about reimbursement. So he said one of the big challenges we have here is in this country, everyone believes that we upcode all of the evaluation and management codes, right? And there's this constant battle, and we have a hard time defining that. And the lady from South Africa says, I don't understand what you mean. We only have one evaluation and management code. So we asked her, well, how do you deal with different levels of severity and complexity? We look at the diagnosis code. We don't pay the same for a runny nose as we do for someone with a diabetic coma. Right? So that balance between the procedure and diagnosis code is very rapidly shifting. Now, this has already happened on the hospital side, and I just want to show you this because this kind of, and I know you can't read this, but let me explain it to you. This really illustrates how documentation at the clinical level has a big impact on payment. Now, this is hospital payment, but let's assume this is bundled payment, and let's look at this as we start looking at risk adjustment. So here we have a patient who came in with abdominal aortic aneurysm, and it was ruptured, and this patient had shock. But in this scenario, it was documented in coding that the patient had acute post-hemorrhagic anemia and hypotension, and the payment was about $19,000 through that DRG. In this case, we said the patient had the same thing, acute post, but made the diagnosis of hemorrhagic shock. Payment was $28,000. However, it's very interesting that for the same patient, defined as post-procedural shock, they got paid $19,000. Both cases were shock, but one was defined as post-procedural. Now, we see this in a number of different conditions, that if you define a complication and you describe it as post-procedural, the assumption is it's a complication of the procedure. So in the documentation, you have to be clear. If that patient comes in and has a fracture of the hip and has postoperative hemorrhage, was that hemorrhage related to the fracture or was it related to the procedure? And if you don't state that it was related to the injury, or don't have evidence that it was related to the injury, it'll be assumed it's a complication. So why is that important? Well, one, it's important because it makes a big difference in payment. It's also important because we are under a great deal of scrutiny now about our complication rates, quality, hospital-acquired conditions, and other types of things. So it's very important that if a patient has a condition that we describe cause, and we don't just say post-op, because that becomes an issue. The other challenge we face is that because of all this scrutiny, we're seeing things like rack audits. Have any of you been through rack audits before? Yeah, we've had a few people. It's like being put on the rack, right? They're properly named. But here was this experiment, and CMS, has really struggled with trying to control costs on the front end because they can't say no to anyone. So they decided, well, maybe we just get this money on the back end, right? We'll get it back. So the rack audits were designed to look retrospectively at the documentation and the coding and determine whether the coding was supported by adequate documentation, and if not, they could recover the cost. Now, this is different than fraud, waste, and abuse. This is not having supporting documentation for the coding. And if we look at what they did in their trial, very limited amount, few $1 million here. This was in millions of dollars. But when we get out and see as they start rolling this out from the pilot phase, fiscal year 2012, $2 billion in recovery. Now, this is recovery of dollars, right? We look out the first quarter here of 2013, and we kind of, because this is the only data we have, we're looking at about $3 billion for 2013. So, pretty big impact. We also know, and this is just an article that just came out this past March that talks about the return on investment for fraud, waste, and abuse. $27.8 billion in return. Right? So, as we've mentioned, there are attacks on all fronts. Now, how do we avoid this? The key way of avoiding this is whenever we code, A, we have the documentation to support it, and B, we code to represent as accurately as possible what the patient's condition is and what we did to improve or maintain that condition. Anytime you start fudging that coding, because this code pays instead of this, then you start getting into that area. You have to stay focused on representing as accurately as possible. If the payer is not paying correctly for the intent of the policy, you need to have a discussion with the payer. But once you start modifying what you put in that code, because this one pays and this one doesn't, you're stepping into that gray zone. And the recoveries have been substantial. So data, why is it important? Well, it supports more equitable adjustment of payment and quality and efficiency measures based off risk, severity, and complexity. That's a key and important factor. It supports proper payment and reduced denials, provides better business intelligence. It supports population-based clinical research. There's a lot of focus on population health. It supports interoperable sharing of data across stakeholders because it is the only national and to some degree international standard that we have across all stakeholders in the industry that defines the patient's health state. We may have all sorts of different things we use internally and for studies, but in terms of looking at the continuum of healthcare data, it's the only standard we have. Everyone looking at that data believes it's accurate and correct. And if it's not, to some degree, we only have ourselves to blame. A couple years ago, everything seems a couple years ago. My granddaughter was just born a couple years ago, and now she's graduating from, into high school. So, a few years ago, I was working with University of Washington. We were doing a study called the BOAT project, the Back Outcomes Assessment Team. And we were doing the study, and we had a lot of money in this grant. We brought the orthopedic surgeons in Washington to the Edgewater, nice hotel, and put them up for 3 days, and we presented them with data. It was a great experience, and being the data geek I was, and somewhat naive in presenting this information. And at that point, I was president of the State Orthopedic Association that year. And so the university says, here, you present it. And being naive, I did. So I presented this data, and we were doing a study specifically on discectomy plus fusion, right? And looking at our rate of discectomy plus fusion in Washington compared to other states. Particularly, we looked at Maine as our cohort in this AHRQ study. And what we found was our rate of discectomy plus fusion was 10 times what it was in Maine. Now, all the studies suggest that you probably shouldn't be doing discectomy and fusion at the same time on a regular basis. It clearly pays a lot more, but there's no evidence that it substantially improves the outcome. So we were way out. So I presented it to my spine surgeon colleagues, and of course I got huge pushback. Folks said, Joe, this data is ridiculous because it's based on claims data, and we know that claims data is worthless. I went on and on and on. So finally I had to respond. I said, where does this data come from? He said, well, it comes from us, but it's for billing purposes. We go, wait a minute. So what you're telling me is what's on that claim does not accurately represent what you did or what the patient's condition was, because we need to look at the Medicare fraud definitions. It is no excuse to say it's bad data. The expectation of anyone looking at this data from the outside looking at us is that it's accurate. And if it's not, we can't say, well, it's bad data. You just can't do that. Or it won't. You can, but it's not going to stand up. So it's important to capture good data for a lot of reasons. The most important reason to capture good data is for good patient care. That's the whole focus. And there's nothing contradictory with good patient care data and the data we need for other purposes. It's all one the same. Hopefully I'll be able to convince you of that. So why ICD-10? Well, besides the fact that it's a law, right? It's a HIPAA law, by the way. It's a law. Everyone else in the world is on ICD-10, almost, except us. And the fact that, we really have been, we're operating off a 30-year-old standard. In Lots changed in 30 years. So we kind of, but beyond that, ICD-10 with all of its lumps, and it has a few, provides a much better choice of data elements to better define the patient condition. It provides the ability to define risk, severity, and complexity to a greater degree. It provides a greater level of interoperability. It allows for better surveillance of the population. And it supports a more robust payment model system. Right? We may say, well, we're happy with the one we got, but that doesn't matter. It's going to change. We're going to other payment systems that are going to be based off of complexity. So I don't think there's any doubt about that. So the quick facts, as you know, it's been around for a long period of time. Adopted in 1990. It's taken us a long time to get there. Almost everyone else in the world used some version of ICD-10, but we all use our own version. There are 12,500 codes in ICD-10 International version that we all kind of gel on at about the 3-character level. But beyond that, we all have our own versions. We have ICD-10 CM. Canada has ICD-10 CA. And Australia has ICD-10 AU. I thought ours would have been ICD-10 US, but no, it's CM. Anyway, we have 69,000 codes, so we kind of supersized it. Compliance date, October 1st, 2015. We have seen that move several times. I can tell you that you know, I do a lot of work with CMS. Probably 60% of the stuff I do is with CMS. I don't think this date is going to move anymore. It's already hit the barriers. Right? And besides that, the rest of the industry is so moved in this direction. If it got delayed once more, it would be billions of dollars impact to the industry. It would be a huge issue. So I don't think it's going to move. And then there's this thing called ICD-10 PCS, which are the inpatient procedure codes. Now, in the outpatient setting, and even billing from a professional claim in the inpatient setting, you don't have to worry about these. Thank goodness, because these codes will drive you crazy. These are really, really difficult codes. And they don't sort of fall. But that's happening at the same time. Now, the hospitals are really worried about these because this plus the diagnosis codes form the basis of payment for the DRG. If we look at all healthcare, and as I mentioned, being a data geek, I love getting data. It's the best present I could get. I had a good friend who was worked for one of the payers in the Midwest, and I said, can you get me some data? And she said, oh yeah, I think give me 3 years worth of Blues data. And this was the Blues that covered all lines of business. Not a huge plan, but about 1 million lives over 3 years, so a lot of data. Right? About $10 billion in charges, so I was in heaven. I had all this data. So I started looking at this data, and I'll show you some things we found with this data. But first off, where do we set musculoskeletal diseases compared to other categories? And this is looking at the very highest level AHRQ clinical classification scheme categories, which I usually do in these. If I look at charges versus percent of codes in that data, we're right up there. Musculoskeletal big in terms of volume and in terms of dollars. Neoplasms, pretty high in terms of, much less in terms of volume. And if we look at the codes in ICD-10, about 45%, depending on how you define it, because there's a lot of other codes that are musculoskeletal related, but these are pretty solidly, about 45% of them are musculoskeletal related. And if we look at it in terms of where these codes are, so about 27,000 codes, fractures, muscle and tendon, this is kind of how they break out. Now, what I didn't include here is the external cause codes, which we'll talk about, because those are progressively becoming more and more important, and they've changed very differently in ICD-10. By clinical area, you see, we really got hit with these codes. We've gone from 747 ICD-9 codes to 17,000 codes for fractures. Poisoning and toxic effects, quite a few new codes. OB got hit, but it's interesting, for OB, for almost every OB condition, there is a code for first trimester, second trimester, third trimester, and unspecified trimester. So in theory, they should have 4 times as many codes. So actually, you take out the trimesters, they actually have less. Diabetes, more codes, but we've now combined codes. So that instead of using 2, you use 1. So we have more codes for repetition. Mood-related disorders, less codes. Hypertensive disease, half the number of codes. So it all depends on the condition. It's highly condition-specific. Why are there so many? Well, 45%, as we said, musculoskeletal. 25% of all the ICD-10 codes are fracture codes. 62% of the fracture codes distinguish right versus left. And we'll not get into why that doesn't add up to 50%, but anyway, because that gets complex. But 36% of all of the diagnosis codes are exactly the same except for right or left. Right? So we have a lot of repetition. Here is just an example. If you look at the section of fractures, right, and I look specifically at fractures of the femur, and you'll see this true for all fractures at the beginning of the category, the first 3 characters there, you'll see a lot of information, and this applies to all the codes that start with S72. And what it says is that for every code, you have to have a 7th character that says A, B, C, D, E, F, G, etc. Right? And what do these things say? They say initial encounter or subsequent encounter. They say open or closed. They say whether if it's open, whether it's a class 1 or class 1 or 2 or a class 3. And if it's a subsequent encounter, was it normal healing, delayed healing, non-union, malunion, right? Those concepts occur thousands of times over and over again. So it's that repetition, right? Not that many new concepts. For a fracture of the radius, for example, there are 1,700 ICD-10 codes for a fracture of the radius. But there's only 51 unique concepts. It's just how they're all put together. So we see a lot of repetition. Now, why is that important? Because it makes a big difference in how you capture these data concepts. If you don't capture for every patient, whether it was initial encounter, subsequent encounter, or sequela, you're going to be going back for queries on every single one. If you don't capture for a subsequent encounter, whether it was normal healing, delayed healing, non-union, or malunion, you're going to be going back for a query on every one. Right? So building this in to your EHRs, your templates, a number of other things into your data capture becomes very important. So here we have September 2015, patient is hit by a car, has an open comminuted fracture of the right femur. Same patient a month later, same condition. Right? Did a little time warp here. ICD-9, we could use this code to best describe that open fracture of the shaft of the femur. In ICD-10, displaced comminuted fracture, the shaft of the right femur, initial encounter, open fracture type 3A, B, or C. So in looking at this, what you see is that we have a lot more codes. We've gone from 16 to 1,530 codes, but also we're capturing a different level of risk, severity, and complexity. We did a study in Washington. I was on the Foundation for Healthcare Quality Board, and we were doing a number of studies, and one was looking at the cost effectiveness of treating trauma in Washington State across different hospitals. And we picked as a marker, we wanted something to compare, open fractures of the femur. And what we found is one hospital is absolutely predictable to be the highest cost and the greatest number of complications, and that was Harborview, right? Big trauma center. Yet Harborview is pretty good, right? We know that. The guys there do an amazing job, but very complex stuff. But we only had a code for open fracture of the femur in ICD-9 and ICD-10. We have open comminuted type 3, right? There's a huge, huge difference in cost, risk, and severity and complexity, but we had no way of telling the difference. I was given a talk to the Orthpaedic group at Columbia University in New York, and I think it was Dr. Levine there. I was in his office, and it was amazing because there's this gigantic mural of Dr. Neer, kind of the god of orthopedics of my day back then, you know, Charlie Neer, who did all the shoulder stuff. So, and Dr. Levine's a very impressive guy, nice guy, but very intimidating for someone like me trying to talk to him about this thing called ICD-10. He says, Joe, why do I have to worry about this stuff? Do I really care about this stuff? So I said, well, let's talk about this. Let's assume, and one thing about New York university hospitals, they're incredibly competitive. If you want to get their attention, you talk to them about competition with the guys that are literally a block away. So I said, suppose your competitors over here had just heard this talk about ICD-10. They said, we're going to get all this stuff and we're going to get all the details. Right? You, on the other hand, said, why should I care about it? Why don't I just use fracture, femur, unspecified? Right? And they're going the full detail. Now we come back and we look at studies in terms of cost effectiveness, complications. You're going to be considered the lowest risk and severity and complexity, because the lower the level of specificity, the less, in general, is considered to be the lowest level of complexity. These guys over here are going to show a case mix of different levels of risk and severity and complexity, and it will be adjusted. Who do you think is going to look better? Dr. Levine says, I see your point. Right? This is really important stuff. It's just at the moment it doesn't seem very important, but in the aggregate it does, because this is how we get measured. This is how we get risk adjusted. This is how cost is determined. The cost of treating a type 1 versus a type 3 open fracture is gigantic. The complications associated with a type 3, hugely different. In ICD-10 we can recognize those differences. Right? So that's one of the good things about it. Now there's a lot of, again, things that aren't quite what we want. So here we have a patient who's seen for a subsequent encounter for a non-union open fracture, right distal radius, intra-articular extension, minimal opening, minimal tissue damage. Right? In ICD-9, I can capture these medical concepts, and I stress medical concepts because these are the keys to ICD-10, those concepts, because those are the things that recur. Open fracture, distal radius. In ICD-10, I can capture all of those medical concepts. Now, I could use a very unspecified code. There's a secret about ICD-10. You can be just as vague in 10 as you were in 9. For every vague code, like fracture bone, unspecified, there's a code in 10 for that. Matter of fact, there's 2 codes you could use in 10 to cover almost everything. Illness unspecified, injury unspecified. Right? Good luck getting paid on that. So ICD-10 is an opportunity to be more specific. You can be vaguer. And for quite some period of time, I think the payer, it's not going to make, you're not going to see a huge change in this. However, immediately, as of the time we go to ICD-10, CMS and every other, well, CMS in particular, because they're capturing this data, they're going to be looking at the cost associated with these different codes, and they're going to be setting weights. And it's going to be based off of data that starts that day and looking back, so that as we get 1 year, 2 years out, and they've already said this, they're going to start re-weighting based off of historical experience. If their historical experience doesn't capture that during that time, the weighting will not be accurate. So it's important right off the bat to start capturing this, because this is going to be the basis for these weightings. The other thing is, because we have combinations, and people say, oh, well, we're just going to map the old code to the new code, right? Does not work. Anyone who's tried that realizes it really doesn't work. Here we have a code in ICD-9, non-union of a fracture, one code. In ICD-10, we have 2,896 instances of non-union buried inside each fracture, because we now, instead of having those aftercare and non-union codes that we had before, now the description of the fracture and the aftercare or the sequela is now part of the code, and so we have many more. Yeah, You know, it's interesting. I remember getting referrals, you know, from the primary care doc that say, "Oh, I got someone here with a bum leg. Can you be a bit more specific? And can you see him within the next hour?" Right? Yeah. So clearly we need to improve documentation. Now I went back and said, well, is this a new phenomenon? And it really isn't. I pulled this up. This was from 1889. And since the patient is well dead by now, I'm not violating any PHI. Plus, it was on Google, right? You just go out and Google it. So here's this patient who was seen for a disability evaluation in 1889. Yes, they did have them back then. And the patient was complaining that they got shot in the thigh with a musket, and they had got rheumatism because of that. And so they wanted an increase in their pension from, I think it was $2.50 a month to $3, which was outlandish. Right? So they went in, they had the exam, and the physician there, of course, they didn't have electronic health records or anything back then, but they did have templates, so they did this disability exam, and of course you can't read it here, but I went through and looked at it, and here's the presenting problem. Gunshot wound, right thigh, and rheumatism. So that's sort of the mini problem list for this encounter. Basic vital signs. Then the description. 2 small superficial circular scars about the middle of the right thigh. And then he describes received 12 February 1864, slight scar also over the sacrum, the bed, probably related to bed sore, and amputation of the index, middle, and ring fingers at the metacarpal phalangeal articulation. Pretty detailed stuff. Right? No EHR. Didn't even have ICD-10 codes back then, but pretty detailed stuff. Conclusion, sorry, you don't get disability because, you know, rheumatism is not caused by musket wounds to the thigh, so he was denied. But have we improved? Well, here's some of the documentation we're seeing today. Now, fortunately, this is nobody in this room. But this is not an exaggeration. My wife used to do chart reviews for some insurance company back in New York, and so she would get these charts. And some of the documentation was like abbreviations no one's ever heard of before. Even the physician probably doesn't remember what he was abbreviating. This just doesn't work. Now, this is not just poor documentation for record-keeping purposes. This is bad care. You can't know what the patient's problem is. You can't pass that information on for someone else to use if you don't document the important stuff. So what is poorly specified coding? Because this is where we really want to avoid. Well, poorly specified coding is coding that does not fully define important parameters of the patient condition that could otherwise be defined, given information available to the observer and the coder. So a lot packed in there. Right? We only have so much information, but given the information that we have or should have based off the evaluation, we should be able to document the details that are important to that patient and should be able to code them accurately. So specificity clearly matters. I got a big pushback when I was talking to some clinicians back east. Going, why do we have to be so specific about all these details and all this administrative burden of ICD-10? And so we were talking to them, and I was given a talk. We actually set up a little skit. Right? Me and one of the coders. I was the grumpy orthopedic surgeon, and then the coder was the one who was trying to tell me how to document better, and of course I was annoyed by all this. Anyway, we set all this up. And so we did this little skit where we went to she was going to tell me more, but she invited me to a restaurant. Right? So on the stage, we set up a table, with the candles and all that. We had a restaurant. And so we looked at the menu, and she said, well, what would you like? And I said, well, I'd like prime rib, medium rare, a little horseradish sauce on the side. I'd like my asparagus done al dente, a little hollandaise on it. And I'd like a glass of Cabernet Sauvignon, Knights Valley, 1995. I'm pretty detailed about this stuff. She told me what she wanted. She says, let me order for you. So she turned to the waiter on the table, on the stage, and said, you'll have one meat unspecified, some kind of green vegetable, and some kind of red wine. And I'm going, what are you talking about? We expect detail in that transaction. We expect it to be accurate and correct, and if it isn't, the waitress doesn't get a tip, right? Or the waiter. Contractor, would you ever contract and not know what kind of plugs they're going to put in and where and what kind of lights? No, we want that detail, right? Who would go into a shoe and get a unspecified shoe? I mean, even red high heels is not good enough. It's got to be the red soles, right? The good stuff. Right? Plumbing, you want to know what the plumber did. If he said, oh, you had this drainus clogus thing, and I did this sort of unclogus procedure, and that'll be $4,000, we don't tolerate that, right? Or can you imagine getting on a plane, and the pilot says, ladies and gentlemen, we're going to be flying to an unspecified destination, landing at an unspecified time. And by the way, you know that checklist? I was a little busy. Right? I didn't do it. We expect that. Right? So, you know, specificity matters. It should matter in healthcare more. And even though we go, yeah, but that's all billing stuff, that is the data we're producing. Right? It's the transactions that people are looking at. It's assumed to be correct and accurate and detailed. And unfortunately, we've had a disconnect with that. And unfortunately, that's probably going to bite us a bit as we come back and look at this data and find out where we are. So I looked at this 3 years worth of data, and first test I ran was just to see how dollars are distributed. 5% of the codes in this 3 years worth of data, this is all providers, inpatient, outpatient, everyone, 5% of the codes accounted for 72.5% of all the charges. Now that's not a good thing, because healthcare is more diverse than that. And when I dug into those and I pulled just the professional claims, about $4 billion in professional claims, what I found was all those codes that were defined as unspecified, other, or just symptom and finding codes accounted for 54% of the claims. Now, the good news is, at least on the orthopedic side, we tend to be more detailed by that. We're not quite as good as the dentist. Right? The dentists really have detail down. Right? We tend to be better. We know that there's a lot of other folks who just tend to have that very short list and pick pain limb. Right? So what we see in these codes, number one code used in that data set was abdominal pain unspecified site. Now, there's a reason to use that code sometime. But if that's a code you ever use, there was one guy in this group, 3 years, billed $3 million under one code, abdominal pain unspecified. We have no idea what he did. That's a red flag for fraud, waste, and abuse. All the fraud, waste, and abuse systems have triggers. And one of those triggers, if you use a lot of unspecified codes, they know that that's where there's a lot of fraud, waste, and real fraud, waste, and abuse, stuff you go to jail for. So they target that. Pain in joint, lower leg. I mean, can we get a little bit more specific? Where? Pain in limb. That's even less specific, right? Shortness of breath, we have that as a symptom, but hopefully it's resolved at some point. But look at the number of dollars that were billed to that. Knee, leg, ankle, and foot injury. And remember, in ICD-9 and ICD-10, and means and or, right? So in this particular case, we don't know where that is. Right? So folks have started looking at measuring how people are, how specific people are getting. Right? So I'm going to share with you a little study that I did for one of the insurers. And just to give you, I have to back up a little bit. I didn't cover all my non-disclosures. Right? So one disclosure is, or non-disclosure, my disclosure. One of them is I have my own healthcare consulting company that I'm full-time in for the past 7 years. So the other is I'm working with a number of organizations developing tools. Right? So I don't want to sell you any tools, but I do want to share concepts with you. So try and put that in perspective. So here is some studies we did, and I was working with some folks at Carnegie Mellon, and we looked at that data set we were talking about to see whether we could determine different levels of specificity. And we created an index called a specificity index that says, is this a highly unspecified, is it sort of specified? So level 1 is as unspecific as you can get, things like pain, limb, that sort of thing. 2 on up 4 was about as specific as you could get for that particular condition. So we did an analysis looking just at injuries. And here is this particular provider whose overall pattern is to be his coding pattern is to be very vague or nonspecific. 3 years worth of data, pretty linear, not a lot. And this is the high volume and high dollar up here, and low volume, low dollar. The number 1 code was for fracture of unspecified bone. So pretty nonspecific. This is a different provider who has a pattern of being quite specific in his coding. And if we look at just injury codes, what we see is a very diverse pattern of coding, represent the diversity of injuries. But we also look at the top codes here, other closed fracture distal on the radius, a lot more specific than fracture bone unspecified. There are some folks who are actually looking at using these types of coding pattern analysis to not only target different providers and groups for clinical documentation improvement efforts, but also are paying differently based off of this. There is one organization that I know of that actually has a bonus based off of the level of specificity that they're using, and they have substantially improved it. Sometimes being unspecified makes sense. If we're early in the course of the treatment, we don't know what it is. Patient comes in with belly pain, I don't know what it is, right? They can't be specific, they can't even tell me where it is, there's no findings, abdominal pain unspecified. Right? But if that's the same diagnosis I have on the 10th visit, then the question is, what value am I adding? Because all I'm doing after 10 visits is telling exactly what the patient told me in the first place, right? So clearly we're supposed to use those unspecified codes if we don't have reasonable assurance about what it is. And we'll talk about reasonable assurance because that's a very important aspect of the coding piece. But sometimes it does. Now, when we get into ICD-10, we're going to be looking at things where you can be unspecified but it doesn't make any sense. We should always know our right from our left. Should we ever say injury limb unspecified? I mean, there's a right and a left, and unless you're from another planet, that's probably about it. Right? We should probably never do that. As a matter of fact, and I work with a lot of Medicaids. I think I've been to 45 state Medicaids doing training for CMS in the past 3 years. And one of the things we talk to them about is specificity of coding, because there's some folks who say, we're not paying for any unspecified code, and you simply can't do that. But what we are saying is that we should probably not be paying for codes that should not be used. Right? We should never have created an unspecified side because we ought to know. How can we treat the patient if we don't know that? So laterality, anatomical locations, we ought to be able to get better than broken bone. We ought to be able to get into a vicinity, and ideally on the orthopedic side, we ought to be fairly specific whether that was a radial head, radial styloid type fracture, midshaft, what that was. Trimester, we should know which trimester it is if we're going to be treating someone who's pregnant. Known complications or comorbidities. So these are kind of some of the basic things that folks are going to be looking at saying, well, you really ought to know that. How do you treat the patient? But again, sometimes unspecified makes sense. Now, in addition to the primary code, it takes more than one code to be specific. We'll talk a little bit about external causes and other things, but we need to reflect, and particularly when we're looking at complications, risks, severity, factors which rate or change the complexity of the condition, if they relate to the condition we're treated, we want to be capturing that. Because if we don't, then we're not adjusting for complications and complexity moving forward. Now, I wanted to touch on this because this is a a key area, and it's a problematic area for coding in general. I totally disagree with the way they handle this from a coding perspective, but this is what the guidelines are. I'm going to talk about them. If you state in your documentation, suspected, probable, or likely, the guidelines state you cannot code to that condition. Right? You would have to code to something like pain joint, right? Even though it's highly likely, and everyone uses those words differently. Now, the catch is, on the hospital side, and this is because AHA writes the guidelines for implementation, it's okay to code to it if you say probable or likely. Same physician, same data, same everything. You walk in the door and now it becomes the condition, and before that it becomes something less specified. Now, to me, this doesn't make any sense at all. There's no basis or rationale for that. The way to avoid that is, if you say evidence of, it's okay. You can code to it. Now, why it should be that tricky little word, I have no idea. But the guidelines are clear. If I say evidence of X. Now, the bottom line is no one expects the first diagnosis to be perfect or correct anyway. It's going to change. Matter of fact, most diagnoses. If you look at the historical data on a single patient, you see diagnosis change all over the place. That's expected. And it's normal. We expect it to change over a period of time. But if you're tentative about saying stuff, and you always say, well, I know they got high fever, hypotensive, they're coughing up, and I can clinically make the diagnosis of septic shock, but I don't because I say, well, I don't have a blood test to show that, and I say probable, then that becomes a big issue. Right? So it's important to kind of understand that, but the key word there is evidence of. If I say evidence of, it's okay to code it that way. The documentation matters. If you say likely, and you get in a RAC audit and they come back and say, well, you said likely, you don't have documentation to support it, then that's what the issue is going to be. All right, so how do we get from the documentation of the concepts to the coding? Now, as an informatics person, I believe in concepts, discrete, canonical concepts, right? Because those things persist standard over time. Whether it's SNOMED or ICD-10 or ICD-9 or ICD-11, those conditions have been there the same. You dig up a caveman, you'll find you can find people with Colles fractures, right? We didn't know they were Colles back then, but they got them. The condition was there. We just now use different codes. So the thing that's stable are the concepts. So here we see a 27-year-old male seen in follow-up for a Smith's fracture on the right side that was exposed through an open wound, minimal tissue damage, not healed after 6 months. Some key and important concepts that make a huge difference in how I would treat that patient. Now, not stated explicitly, but implied is it's fracture radius distal, dorsal angulation, extra-articular, and it's displaced. And since I said it was minimal opening, minimal tissue damage, that tells me it's a Gustio class 1. It's not healed after 6 months. It's a non-union. Those are important things. All of those make a huge difference in the risk, severity, and complexity about what I would do for that patient. I would treat a 87-year-old female differently than the 27-year-old male. Right? Different risks, different complications, different treatment. So let's just look at those concepts. Here's the concepts. Has no idea what code they're going to be. But we're trying to turn those concepts into data. And to do that, we have some tools. We have ICD-9. We have codes like SNOMED, which are used primarily on the electronic health record side. We have ICD-10. And what they're all trying to do is capture that data as much as we can. Now, in ICD-9, I can capture these concepts, fracture radius, open distal. In SNOMED, I can capture with a single code, I can capture these concepts. In ICD-10, I can capture all of them. None of them can I capture the fact that this is a 27-year-old male. I need to capture that in a different field, one called sex and age, right? But to capture that, I need to capture those concepts. So, what do we need to document? What are those concepts? Well, the interesting thing of it is there's nothing new about ICD-10 that we weren't already doing already. Right? or should be. Right? And I was talking to some folks about, documentation, and they were looking at all these things and saying, oh, I get it. That's the same stuff we were taught in medical school and residency. I remember being on grand rounds in University of Arizona. Dr. Peltier, my professor, would come around, and he would come with his entourage. He loved his entourage. I swear in a prior life he would have been Henry VIII. But anyway, he'd bring his entourage around, and you'd have to stand at the bed, and you'd have to present your case to the entourage. And you were supposed to present all the key and important medical concepts that made a difference in treating that patient, risk, all those things, right? So I'd present this patient, I'd say, Dr. Peltier, this patient is a 27-year-old female. She was hit by a bus, and she sustained an open comminuted fracture of the left distal femur. It's intra-articular and involves both condyles. It's intracondylar. And I would go through all of this stuff and describe that it was a Gustio class 1 fracture class, or whatever it was. And after laying all that out, then there was usually a medical student or a junior resident who wanted to impress Dr. Peltier. And so they would ask that question. Dr. Nichols, I was just thumbing through the chart here, and I noticed that this patient is a type 1 diabetic. You didn't mention that to us. And Dr. Peltier would turn to me and say, Dr. Nichols, can you explain yourself? And I'd have to go, oh yeah, that's important too. Right? Of course, I beat up on the medical student later, but that's the game we played, right? Get all the stuff, right? Don't leave out any of the stuff. It's what we're talking about today. If we look at, and I just put these in here not because we don't know what we need to document for things like arthritis, but look at some of the concepts that are now captured in ICD-10. They're quite familiar, right? Types of arthritis: rheumatoid, juvenile, systemic onset, associated with rheumatoid vasculitis. These are all concepts that we're familiar with, or should be to some degree. If it's infectious or pyogenic, is it related to mumps or staphylococcus or rubella or meningococcal type? So these are all concepts, again, that when documented have codes associated with them. Types of inflammatory: sarcoid arthropathy following intestinal bypass, post-dysenteric. Now, a lot of these we're rarely going to see, if at all, but if they're present, we can now capture those concepts. Gout: idiopathic, drug-induced, chemical-induced, or lead-induced due to renal failure. Other crystal arthropathies, including chondrocalcinosis, calcium pyrophosphate type. Osteoarthritis, with its primary, secondary, post-traumatic arthritis, neurogenic, or Charcot joint. Now, you won't find this in the arthritis section. You'll find it in the diabetes section. Hypertrophic osteoarthropathy associated with neoplastic disease. Distribution: posteoarticular, monoarticular, lateral. What are the time parameters? Well, things get left out a lot is just whether it's acute or chronic. Now, there was this one of the hospitals I was at, they looked at the cost of not stating whether it was acute or chronic in terms of DRG impact, and it was huge, just not using that term. And yet, it's just a common term that we use. It's nothing new to us. It's just new in the fact that we can now capture this in the codes. Time parameters: whether it's erosive arthritis, whether it's primary, secondary. So here's what some of those inflammatory arthritis codes look like. See, most of these here are 6 or 7 characters. Now, almost all the fractures are 7 characters, right? Because they have to have that 7th character thing for it. There are some codes that 4 characters is perfectly valid. There's some codes that are actually valid at 3 characters, right? Most of them are going to be more 5, 6, and for fractures, most of them are going to be 7 characters. But here's the type of codes we see: traumatic arthropathy, posteoarticular, post-immunization, Hemophilic arthropathy. Fractures. Now, that's where most of the codes are, right? 17,000 codes related to fractures. But again, almost all these codes are repetitive in that they use the same concepts over and over again. And I've sat down and done the experiment of just taking and building a fracture related to impact. We can perhaps look at one of those. But basically all it does is try to capture those concepts so that it'll take you consistently to the right code. Initial, subsequent, encounter, and sequelae. Now what I have here is how many codes include those concepts, how many at PAT. Initial, 5,310 codes. Subsequent encounters, 11,328 codes. If you don't capture this information, it's part of the intake process. And it doesn't have to be the physician capturing this stuff. As a matter of fact, we'll talk a little bit later, I think it's this afternoon, we're going to talk about reducing that burden of data capture so that it doesn't interfere with the patient-clinician interface, but actually gets pushed forward by changing the intake process, changing the MA, scribe, or whoever is capturing, the interviewer. You can capture most of this data outside of the patient-physician interface. That we want to try and protect as much as possible. But it needs to be captured somewhere, and it needs to be reviewed and confirmed at some point, saying, yep, I've seen all the data, sign it off at the bottom. Healing patterns. If this is a subsequent encounter, for every subsequent encounter, you got to state whether it's normal healing, delayed healing, non-union, or malunion. Just build it into your template, right? Every fracture that's seen. Laterality. Spatial localization. Is it proximal, distal, medial, lateral? And you have to, we'll talk about this a little bit more, you have to be careful about how you use words to find these codes, and I'll give you some illustrations of that, because sometimes the words are not the words you expect. Fracture patterns, displaced or non-displaced, 10,000 codes impacted by that. Now, again, this is sort of no-brainer stuff. We should, if we're documenting fractures, say whether it's displaced or non-displaced. In theory, we should be stating whether it's intra-articular or extra-articular, whether it's an avulsion fracture, whether it's transverse, oblique, spiral, longitudinal, simple. Nothing new about these concepts. What's new is there are now codes related to these things that we perhaps didn't have in ICD-10. Fracture patterns. Is it osteochondral? Is it articular? Is it a blowout fracture? Is it longitudinal pylon? What's totally new to ICD-10 is the ability to grade. I mean, we've always had this before, right? We've had that Castillo classification for a very long period of time. It's just now, if you see a patient with an open fracture, you can classify, or you have to classify in most instances, not always, but which Castillo class it is, right? Is it a class 1 or is it a class 3A, B, or C? Right? And they're broken out like that. There's a code for type 1 or 2. There's a separate code for type 3A, B, or C. What would I want to do in my office? I want to make sure that any time I saw a patient with an open fracture, and hopefully we don't, those are the minority of the ones we see, we capture that information. Because otherwise it's going to be a query back. Physeal fractures, epiphyseal type injuries, fractures. It's always been important to have, say, whether it's Salter 1 or Salter 4. Right? Salter 1 I can almost ignore. Right? Even if it's displaced, it almost always straightens out. Right? You always straighten it back out because mother would not allow it to be stay off. But most of them are actually very forgiving. Salter 4, if I don't get that thing back right, I could end up with a permanent deformity. Right? Huge, huge difference. Risk, severity, and complexity. If I'm looking at treatment of children fractures and I want to look at comparing risk and complications, it's important to adjust for that. If I'm at Children's Hospital and we get all the Salter 4s and all the Salter 1s are treated out here, these guys are going to look real good, these guys are going to look real bad unless we adjust for the fact that we're seeing a different level. So, types of fractures, whether it's pathologic, stress fracture, torus fracture, green stick, osteoporosis. Here's just looking at that Castillo class. This is from Duke's description of that, grade 1. Grade 2, generally less than 1 centimeter. These are generally those things that are not going to involve substantial or severe tissue damage. And then the grade 3s, broken into A, B, and C, which are generally greater than 10 centimeters and generally involve substantial amount of tissue damage. Grade 3C is almost a guaranteed amputation. So huge differences, risk, severity, and complexity. Now, interestingly, we actually have more named fractures in ICD-10 than we had in ICD-9. In PCS, they got rid of all of the named stuff. And CM, the diagnosis side, they actually added more. So in ICD-9, we only had Colles fracture as a named fracture of the distal radius. In ICD-10, we include Smith's, Galeazzi's, Barton's, Chauffeur's, or radial styloid type fractures. Here's what some of these codes look like for fractures. Pathologic fracture in neoplastic disease versus pathologic fracture in osteoporosis versus pathologic fracture in other types of conditions. Left radius, subsequent encounter with delayed healing. Displaced fracture, head of the right radius. Initial encounter for open fracture, type 1 or 2. Torus fracture, the upper end of the left radius, subsequent encounter. Displaced transverse fracture, the shaft of the right radius. So all of those details that in theory we're capturing now, we're now capturing in codes. So the challenge really is first making sure we're capturing the concepts, and secondly, make sure that we can get from those concepts to the codes. Now this afternoon we're going to take some scenarios, we're going to lay out, pull out the concepts and say, how do we get from there to the code? Now, one of the challenges we face, and I started doing some research into different coding tools to look at to what degree do they help us find the codes. Now, a lot of these coding tools work really well in some areas. Right? Behavioral health, really easy, because there has hardly been any change. They're almost one-to-one in behavioral health. OB, the biggest change is trimesters. Almost everything else is the same. So not a huge. Musculoskeletal care, huge, huge impact. Unfortunately, we got the hit. I think to some degree, and my concern is because I don't think we were well represented at the table for a lot of this stuff. The cardiac guys were. Right? A lot of the stuff that they wanted in terms of definitions of acute myocardial infarction, the definition, they were there at the table. I don't think we were quite there. I used to sit on a committee at the Academy, and I talked to some of my former colleagues, and I said, did you know? And I was looking at these ICD-10 codes, and I was saying, did you know that there's no code for an acute rupture of the anterior cruciate ligament? The response was, no, that can't be true. There is no code for acute. Why? I think because we were at lunch or whatever it was, we weren't sitting there at the table. We do have for acute traumatic rupture of tendons and ligaments of the upper extremities, but the lower extremity guys must have gone to lunch because they're not there. Right? So what do we have to use? We have to use a code for spontaneous rupture, which is very different than acute traumatic rupture. We have spontaneous and acute traumatic in the upper extremity, not in the lower extremity. We have some other strange things that go on there, like calcific tendonitis. Almost every tendonitis in the upper extremity is calcific. Right? Hardly any in the lower extremity are, and yet we know that's not the way things really are. Right? But for some reason, and there's no code for plantar fasciitis. Right? There's a code for plantar fibromatosis, which is a different condition. Right? So those are some of the warts we see with this, and I think partly because we haven't been there. Now, one of the things to do at the Wheatie group that I'm involved in, we're constantly submitting what we call errata to CMS and to the committee, NCVHS committee that's looking at these things, saying, oh, by the way, did you know? And some of them they correct, some of them they don't. But they're really missing the specialty input on this, and I think that's going to be really, really important to get orthopedic specialty input into how these codes design, because they are going to impact us for sure. Right? So looking for a code. Well, you know, typically this is actually a super build just like mine. I won't say it was my super build, but it's just like mine. You know, nice single page thing. I put everything kind of in lumps. All the radial fractures we kind of had over here, which of course really weren't radial fractures, or weren't Colles fractures. It says radius Colles. It wasn't really, but very limited set of codes. There were actually 32 codes. I had a few here. ICD-10, 1,731 codes. And each one of them is different. And so to do that, I'm looking at a super bill that's 150 pages long. I mean, it just doesn't work. It really doesn't work anymore. And it really never worked quite right in the first place. So we have tools to find these codes. And part of the challenge is because we have so many codes, because they're so combined and there's so many different moving parts, sometimes it makes it a little hard to find. So about 4 years ago, I went and got certified as an ICD-10 coding trainer, so I could say I was. And did the online thing. You have to do this online thing. And then you go to Chicago or wherever. They're doing it for 3 days. And you sit in a room and you do this. And then 2 weeks later, you can take the test. And if you pass the test, you can get certified. Well, I went to the room. You know, there's 350 other people with me in Chicago. They were all female. They were all coders. I think I was the only physician there. And we had a great time. And I learned a whole new respect for coders. This is a tough, tough job. It's tough to get it right. And it's also becoming even more important. But I had to go through the same exercise. They said, since you are orthopedist by training, you cannot do anything orthopedic. You have to do, and we all had to do these scenarios, right? And then we had to turn them in. Your scenario is you have to look up something different than orthopedic. So I said, I'm going to pick something relatively easy and straightforward. Coronary artery disease plus angina. So I pulled my little scenario there. I had it looking at that. So I started doing what I was told to do, which is go to the alphabetical index and look that up. Go to the alphabetical index and I look under coronary artery. It says C condition. Okay. So I look under condition, C disease. Now I'm new at this. The other coders in the room say, you never do that. We all know that, right? Because they've learned that stuff before. So I looked under disease, coronary artery, C disease, heart ischemic atherosclerotic. So I went and looked under disease, heart ischemic atherosclerotic, with angina pectoris, C arteriosclerosis coronary artery. Looked under that one. I thought I found the code. But no, that's not the code because you have to go to the tabular index and look it up, right? You can't code for me. So I went to the tabular index and I read all the stuff in front of it and behind it to make sure I was looking at all the guidelines and everything else. And I said, I think that's it. And then I went back and I looked at my scenario and, oh, this patient had had a bypass. Well, now it could be this code or it could be this code or it could be this code or it could be this code, right? Now, the good news is that we don't have too many orthopedists coding or else we would never get a bill out the door. But this is not simple stuff, right? And particularly when we get 69,000 codes and now we've combined a lot of stuff, it's not where we expect sometimes. Just for example, looking at something like arthritis, you would expect to find all that under the chapter disease of the musculoskeletal connective tissue. Well, most of them are, but not all of them, right? Here is where other arthritic conditions are spread through other chapters. If I looked at something like pneumonia, for example, I might find a chapter called pneumonia and influenza. There'll be, I think it was 15 codes in there. But there's actually 150 codes, or I forget the number, what it was. I did the in 12 different categories, right? Because these things are not all in one place. If I have diabetes plus congestive heart failure, do I look in the congestive heart failure section or do I look in the diabetes section? They have diabetes plus congestive heart failure and renal disease. Which place do I look? Because it ends up going in one bucket. So because we've combined stuff, it makes it a little harder to find some of these things. And this is probably a code you're pretty familiar with, aftercare, right? If I see a patient come in and they've got an injury to their, their forearm, here's the code I pick, right? Now, there are a total of 18 codes related to fracture care in different areas, right? But I would pick one of those. In ICD-10, we don't have those codes anymore. We have a specific code for the fracture, that it's a subsequent encounter, and whether it's routine healing, delayed healing, non-union, or malunion. Now, there's actually separate codes that we had for non-union, malunion. But just for aftercare, we had 18 codes. We have now 5,828 codes for aftercare. Because you now have to attach the aftercare to the actual injury. So the bottom line is, and I love this quote, if you don't find it in the index, look very carefully through the entire catalog. So what does this mean? It means you need a tool, right? But you have to be careful about evaluating tools and know their limitations. And this is something that, and it actually drove me to do a lot of research around concept sort of base mapping, which I'm not going to get into to any significant degree. But the whole idea is that if we use word searches, sometimes we don't quite get there. Because sometimes the words aren't what we expect, and sometimes they use a different word. It really doesn't work quite the way we expect because we think concepts, right? Not specific words, and I'll show you some examples of that. So you got to evaluate these, and the way you evaluate them, and again, we'll talk about creating scenarios and walking through them this afternoon about how you walk through that process. But you need to create a scenario of things that you see commonly or that are going to be high dollar, high volume, high risk, or high complexity. And you create some scenarios, and you don't believe what's shown you, you have to actually test them yourself. So I got this note, and I get these all the time. People say, hey, we've got this great new tool. You might want to tell everyone about how great this tool is. And so I, it says, whether you're a physician or coder will help swiftly and accurately identify codes, typical marketing language. What's interesting here is that if I put in the stuff that I'm thinking about, right? Patient with a fracture of the proximal femur, no codes. If I say, well, maybe they call them hip fractures, right? Fractures of the proximal femur, and I put that in, I got some codes, but these are the codes I got. These are stress and pathologic fractures, periprosthetic, probably the least common fractures of the hip I'm going to see. This is their entire list, and you see here, chip fracture of the right talus, because they're looking for those characters, right? And they're bringing those things back. But for all fractures about the hip, including acetabular and other fractures, there's actually 1,585 codes. What they didn't include were subcapital, intertrochanteric, subtrochanteric fractures, intracapsular fractures, fractures of the neck. They're all hip fractures. They're all fractures of the proximal femur. They just don't use the correct word. Right? So I was fortunate enough to get a common orthopedic tool that some of you may be familiar with and tried it there because this was a little bit more sophisticated tool. So I did the same thing. Find me all fractures of the proximal femur, and no codes were found. Right? So I said, all right, let's look, because let's use the word fractures of the upper end of the femur. And we found 67 codes. But we only found codes that used the word upper end. I didn't find all the codes related to proximal femur fractures. That's the concept, right? So here's fractures of the upper end. Sorry, this one here, yeah, fracture of the upper end of the femur. But the real answer is 1,078 codes that involve fractures of the upper end of the femur. There's a few codes missing in this list. So the challenge really is with any of these tools, now clearly I can ask it different questions a variety of different ways, and most of the time I can get there or close, but a lot of times it doesn't quite get you where you want because we're not doing concept-based searches. So that's one of the things, and I was doing some research on that and actually put together a mapping tool that was concept-based. And so I used that for training and for teaching. And clearly it's not a product at this point. But the idea of being able to take a code and say, you don't say that you're intra-articular, but you're a Barton's fracture. You don't say that you're intra-articular, but you have intracondylar extension from a distal femoral fracture, so you're intra-articular. You may not say that you're distal radial, but you're a Barton-Smith, Galeazzi, and you are distal radius, right? So part of that is mapping those concepts to it, so that when you apply those concepts, regardless of the words used, it pulls in all the codes. Now that's not a small undertaking. So far I've mapped 520 concepts, and the number of code concept associations is about 500,000, right, to get there. But that's the challenge that we're facing. Unless we can get at what's in our brain from assessment to the code, that's the challenge we're facing. So the key is understand. Now, there are lots of good tools out there, and a lot of these tools will answer a lot of the questions you want. The challenge really is you've got to be mindful that in some instances, the words you use or the things that you're expecting may not be there. If you look for acute traumatic rupture of the anterior cruciate ligament, you're not going to find a code. Right? Just not going to be. If you look for an open Castillo class 1 fracture of the humerus, you're not going to find a code. If you look for an open Castillo class 1 fracture of the forearm, femur, or tibia, you will find a code. For some reason, it wasn't in the humerus. If you look for an open fracture, pathologic fracture, you're not going to find a code. You're actually going to have to use 2 codes, one for the pathologic fracture, one for the open fracture. Right? But understanding those things is a challenge. Right? That's our big challenge, is really understanding what's behind all of these different codes. Yeah, so when I ran it, just put in fracture of the hip, I ended up with 1,522 cap. And it includes all of those, whether it says it or not. Now, one of the things I did want to share with you, I have a tool out there that's free, so I feel perfectly okay to tell you about it, because I'm not selling it, it's free. There is a tool out there on my website, and this is a GEM mapping tool, called a general equivalency mapping. And what a general equivalency maps are is something that CMS and 3M came together and said, we're going to ICD-10, here's your 9 codes, what would be the equivalent codes in 10? Right? Now there's all sorts of challenges with this GEM mapping, and I have a full page of disclosure saying, you know, what you need to do and how you need to do it. But it's free, and in other words, CMS puts out these files on a regular basis, and they're all public domain, but they're very difficult to use unless you have an IT background to use them, because you got to map things together. So what I did is put all those out there so that there's a tool so that you could go out and use that particular tool. And basically all you have to do is take a code or a list of codes, put it in there, say whether you want it to go from 9 to 10, and it'll bring all the 10 codes that would relate to that code or that group of codes. I could put in all the fracture codes, and you know, if we had time we could demo that, but we could put in all the fracture codes and it'll bring all that. So I'd say that with a little reluctance, because you've got to be careful about using mapping tools, because frequently they bring you into the wrong area. But it can give you an idea. If I put in non-union and I do bidirectional mapping, it'll bring me back all the codes that have non-union. So anyone who wants to use that, you can just go out to my website, Health Data Consulting, go there. You have to sign up to get to the tool, but it's totally free, and you can use it for whatever purposes you want. It's good for researching. Right? If you want to research the codes you use today and see what the equivalent codes would be in 10, you can find that. So, getting started. 1, training. You've got to do role-based training. Almost everyone needs to know something about it, whether you're coding or not. It really has to do with, are you capturing the right data? Right? Do we have intake forms? Do we have interview forms? Do we have MAs that are collecting information on the way in? Do we have, as many places are going to scribes? Right? I'm doing training for a group of a company that markets scribes to people, and basically what we're doing is training them about what data needs to get captured for these types of things. But you have to think about what it is you need to capture. If you have an EHR, you've got to make sure that your templates allow you to capture the stuff you need to capture. And it's not really that difficult. You just have to go to those areas, see what those recurring concepts are, and make sure that they're in the template, particularly the ones that recur over and over and over again, the really common ones. So getting the right level of training to the right people. Communication. Referral and order processes. I was just talking to a group of radiologists and pathologists, and they're very concerned that they get the information they need. They're concerned that they're going to have to go back and query the referring physician to make sure that they get the information they need to do. Important to monitor, and I'll talk about this in a second. We know that this is one of the biggest changes that's happened in healthcare information technology in decades. We also know that these codes play dramatically into risk adjustment, capitation, payment, coverage decisions. I said I've been to almost every Medicaid in the U.S., and we've reviewed their policies, and almost all of them have coverage decision that looks at specific types of conditions to determine coverage, and all of those have to be redefined. So almost every payer is redefining their rules. They're particularly redefining rules around third-party liability, because that's a big, big piece of all of this. And all of those rules are going to change. Now, the chances they're going to do it perfectly are pretty unlikely. So what does that mean? There's a high chance, and unfortunately, a lot of these rules don't get that deep into orthopedics, so we're a little bit more insulated from some of these rules than some other organizations or some other types of specialties. But there is a risk that we're going to see rejections and denial rates change, claim lag particularly change as these systems are being billed to paid ratio potentially changing. The hospital side is really worrisome, right, because there's a lot of shifting of DRGs that's occurring based off of relatively minor things. Coding patterns and testing. We'll talk a little bit about testing a little later this afternoon. So what are the key metrics you need to have? Well, clearly you need to know what your current claim rejection rate is historically and trended over a period of time, because we know they vary over a year. Sometimes they may go up or down or with different. So what is the rejection rate? What's my pattern? Did something happen on October 1st where suddenly my rejection rate became new? There was one of the payers in the Midwest was doing a what they call a smoke test with the OB specialty group there. And they all got together and they created some scenarios, and the representatives of the OB group said, well, we're going to send you some trial claims. We want to see, are you able to accept them, and can you adjudicate them? And the payer said, we're going to run end-to-end testing. Well, what happened is when they sent these in, they found 45% of the claims on the first pass failed, were rejected. And they rejected for one reason. They rejected because the OB claims had a 0 instead of an O. Because today we have an O for some things in ICD-10. There are no O's for the first character in ICD-10. So, but because of that. Now, it was good to find out that 45% of your claims were rejected before you go live, right? So that you could fix that problem. Testing is a good thing, but it's important that you monitor what happens, because you want to get 6 months, a year down, found out, boy, you've got this big problem down here, you didn't even notice it, right? You want to monitor that as you go. What's happening with the rejection rate? What's happening with my denial rates? October 1st, suddenly I'm seeing a change. Where is this change occurring? With which type of payers? Is it happening with Medicaid? Is it happening with Regents? Is it happening with someone else? Billed to paid ratio. Here's what we got billed before, and here was the ratio, 5%. No, It's usually a little higher than that, but there's a ratio there, right? We build this, and we normally get paid on aggregate about 35% of what we bill, if we're lucky. Right? Did that ratio change? Now, that didn't tell you why, but it does tell you something changed, right, during that period of time. Claims turnaround. Suddenly, has the claim turnaround changed? Right? And with a particular payer, or even in your own office, if you got different providers who are showing different changes in some of these things. Good to know. All of a sudden, for one provider, everything's getting rejected. It might be a problem, you know, with that particular coding. So what do you need to do as actions? Well, you need to create a baseline, ideally, and this is for any trending of claims, you need almost 2 to 3 years of claims to trend, because you need a full year just to see the variations during the year. Monitor metrics at least monthly. Localize where your issues are, which payer, which provider, which type of conditions, and then create some type of rapid intervention plan. The sooner you get on this, obviously, the better to address it. So, I was going to Eastern Washington on one of those wine tours, right? And we were driving along, we came to this fork in the road, literally, and I saw this sign there, and of course I had to get out and get a picture of it. And what was going on was, up here was a trailer with a big truck, and the other side was a wine tasting event, right? And people kept going up the wrong road, and so the guy up here in the truck put up that sign, right? This way to the wine tasting, this way to the angry redneck with a shotgun. Well, that changed behaviors a bit. I think we're really coming to a decision point in terms of how we're capturing data as part of doing business. And I think that there are choices. We either say, it really doesn't matter, I'll worry about it when it happens, or we start really looking at where data and accuracy of data and getting ownership and understanding that data better than anyone else becomes critically more important. And to me, you know, sometimes the choice is clear. Now, that being said, I'll tell you, if I was in practice and doing this, I would want to do the minimal amount I absolutely had to do. But I think to some degree we've got to start thinking a little bit further than that, because there will be a price to pay if we really have data that we don't understand, that no one else can understand, that really doesn't affect what we do, and that we're going to have a hard time explaining why our costs are so high and why our complications are so high, when really they aren't. Once we adjust them for risk, severity, and complexity, they may actually be quite good. Harborview does great for Castillo Class 3. I know they do, but I can't prove it, right, because I don't have any data. We don't know how they do. But that's my guess. My guess is if we all submitted that data, Harborview would look pretty good compared to everyone else for treatment of those, because that's what they're good at, those hugely complex fractures. All right, so let me just stop there and see if there's any questions. Yes?
So things like plantar fasciitis, rotator cuff tendonitis. For plantar fasciitis, do you use the code for nodular plantar fasciitis?
You have to use for you have to use plantar fibromatosis because there is no other code. All right, sorry. So the question was, if you see a patient with plantar fasciitis, which code do you use? You use the closest one you can, which happens to be plantar fibromatosis.
And for rotator cuff tendonitis, if it's not calcific,
You're stuck. You have to say calcific, right? Because there is none for non-calcific.
how close that is brought?
Not at all. Not at all. You are using the code that most accurately represents the condition given the codes available and the knowledge you know, right? That's the rule. They can't blame you for glitches in the coding system. Yeah.
So, nothing spoils results like poverty. And to what extent can we include comorbidities, or do we need to, so that our profiles and our billing is adjusted appropriately and so that we're not penalized?
Good question. So, again,
especially when the lowest payers are usually the highest risk.
right, particularly for like the Medicaids and those types of things. So we've traditionally been a little lax on reporting comorbidities, right? We report the thing that we're going to see. So the question was, what do we need to do to, if we see patients with comorbidities or other risk factors that we want to, recognize that, should we do that? And the answer is, of course we should if it impacts what we do. Now that doesn't mean you throw every code possible at it, but those that are relevant or make a difference in risk, severity, and complexity. If I see a patient come in who's got an open fracture and they have type 1 diabetes, I'm not treating the type 1 diabetes, but it sure can have an impact on the nature of that patient's condition, risk, severity, and complications. And other. If I see a patient and I treat them with a total knee and they happen to have claudication due to atherosclerosis of their lower extremity, is that amputation they end up with because of me, or is it because of their atherosclerosis? Well, if I have nothing that says atherosclerosis, it's going to be assumed that it's a complication of the knee procedure. Right? So I think that where relevant, where it would make a difference in risk, severity, and complexity and define further the nature of it, you want those codes in there. Right? Because to me, I don't look at ICD-10 as the enemy in this new data-driven environment. I actually look at it as your friend, because before you could not recognize that difference. Now you can't. It's just tougher to do. You have to have better approaches to finding the right codes, and it's a challenge to do. Yes?
Two questions. How do you account for time? Increased time.
How do you account for time? Right. So lots of questions buried within that. So one of the questions was, it's going to take a lot more time, right? It's a burden, right, to do this stuff. Well, I don't think the documentation is a burden, because I think the documentation we should be doing for good patient care anyway, right? The challenge really, to me, the biggest challenge is finding the right code. Right? That's the hard part in all this, is finding the right code. So that's one piece of it. And I think there are strategies for reducing that time and that burden. We're going to talk about that a little bit this afternoon, but how do we capture good data without burdening the patient-physician interface, right? I go to seeing my doc, I don't want him sitting there and just working on the screen like this and making no eye contact, I don't want him doing that, right? I'm perfectly happy to have the person who's interviewing me or the MA or the scribe or someone doing that. That's their job. But when I'm talking to my physician, I want them to look me in the eye and understand. And I also want him to have all the information he needs. There are strategies for moving that data capture away from the physician-patient interface. Right? It takes some work in building templates and the right things you need in place and intake processes and those types of things. But you can do that. So I know that's one. The other big part is the other part you were talking about in terms of reimbursement, in terms of making sure we get reimbursement that we get today. It's close, revenue neutrality, so to speak, right? And let me tell you that revenue neutrality in ICD-10, though it's talked about a lot, is a myth, right? Because we're changing the whole apple cart. Now, I do think that one thing that's important, and John, I'd love to hear your thoughts on this also, but I think one thing that's important is that we rethink how we approach physician reimbursement from our participatory role. If we continue to say fee-for-service is a particular model that we must have, and our goal is to make sure that that service gets that payment, we're not going to be at the table. I feel fairly confident about that. And I can tell you the hospitals already know that. The hospitals, who are the basis for creating these ACOs and other things, are saying, look, just give me the money, I'll figure out how to distribute it. Right? Well, we're really very much in the back seat. Now, there are some organizations, and even in Florida there was a group, and this was a long time ago, there's a Florida group that said, we're going to take care of scoliosis, give us a carve out for scoliosis, we'll take care of it, and we'll manage it all, right? They were actually very successful. Here in Washington, we had a group of federally qualified community health centers, right? Probably the poorest level of patients, poorest level of reimbursement. They created their own health plan. They took the entire risk. I spent 6 years running the claims processing company for that group. They were highly successful. Yakima Valley Farm Workers Clinic. If you go to Yakima, to this little town called Toppenish, where all the farm workers are, and if any of you ever, it's just a little teeny tiny town. No house, no building is more than one story, except for the farm workers clinic. Right? Beautiful facilities. They've got free daycare for kids. They've got, within limits, obviously. They've got a number of different children's programs. They've got dental services for farm workers and other, and they got it all because they managed the risk at that level. Right? So to some degree, if you don't get at the risk level, if you don't take on the responsibility of control, if you don't drive that, it will be driven down to you. And I'm very concerned that particularly with ACOs and other hospital-driven type models, we're going to see that we're at the bottom end of the distribution. So I really think that we need to rethink how we engage that payment model. But that's just my own opinion. I mean, John, what's your thoughts on that? Any comment?
Well, I remember Representative Schrader telling me how great it was going to be that we can move from fee for service to paying for value, but it stops there. There's, you know, the devil's in the details, and he's got a nice catchphrase, and it sounds good to other people. But as you say, you know, a golden rule is going to prevail, and people who don't have the burden of practicing medicine have all day long to figure out how they can pay hospital administrators more than brain surgeons.
No, I agree, but I think to some degree, if we don't sit at the table in a way that is said, we're here to reduce cost, I'll tell you how let's do that. Let's reduce the amount of money we spend on the hospital side, and let us share in the savings of that. Right now, if the hospital saves money, they get a share of it. Right? So to some degree, if we're not part of that cost-saving equation, I think we're going to have a real challenge. So I think it's going to take a little bit of a re-look at this. I mean, we talked about this a number of years ago at the Academy. At that point, it was all about RBRVS, so we didn't quite get there. But I do think that that's going to be a different model. And that's a real challenge. And you're absolutely right. No one really knows how to define value-based purchasing, but you know what? They're doing it anyway. They're already substantially changing the way. It's just like that example I gave you on the hospital side, where if you say that it was a post-procedural hemorrhagic shock, you get paid half of what if you said it was a hemorrhagic shock that was not post-procedural. Same case, same everything else. So I think we're seeing this happen not very well, but I think it's not happening very well because, to a large degree, we have been not engaged in that discussion. So.
How is this going to work if the emergency doctor codes a fracture a specific way, arrives in your office, that's not correct, you've changed the code. The ED doctor gets paid for this one code, you submit another one with a different code for the same injury of the same patient. Who wins? How does that get?
Well, you win, right? I mean, the anticipation is that when you see that patient, you may come up with a different diagnostic code than anyone else. That doesn't mean that any of them are wrong, right? The guy in the ER may say fracture bone, unspecified. You say it happens to be a fracture of the, Salter-Harris 4 fracture of the distal epiphysis of the femur. That's perfectly valid. Now, if they adjust for severity, you're going to be adjusted, the other one won't be.
Is there going to be some computer algorithm that's going to take ED doctor diagnosis and yours and kick it out and have it looked at with the delayed payment until it gets resolved?
No, and I'll tell you why. If you look at the same patient for the same condition by a bunch of different providers over the length of their treatment, you will hardly ever find the same code used twice. That's the way it is today. We just don't have consistency of use of codes today. The way we code inpatient versus outpatient is for things like probable and likely, that code changes, right? That's what we see today, and that problem is going to persist going forward. So you can't have an algorithm that says, well, if these codes don't match, because it won't, everything will fail.
Isn't the whole point of this specificity in coding over time? It's like, it seems like paradoxical to me that it could be okay to have multiple different ICD-10 codes when there's now so many more of them.
Well, here's the idea. If I'm seeing a patient and I don't have the information, I'm going to use a less specified code. If I'm a primary care physician, I may say that patient has a fracture of the forearm, but I don't know how to describe it better than that. Or I may even, as an ER doc, say the patient has an open fracture, but I don't know which Castillo class it is. That we're going to see. The goal is that we try and get the most specific code we can, given the information available to us, and given the level of our specialty and understanding. So we expect to see more specific codes by orthopedists than we would by primary care docs for the same condition. I think that's an expectation. And I've never seen anyone fail, as long as they have the documentation to support the codes they use. Right? The primary care doc didn't have documentation to support that level of specificity. Hopefully you do. If you don't have that level of documentation and you use that specific code, then it's going to fail an audit. So I think that it's not, I mean, sometimes it seems more complex than it is. It really gets back to the core. What are the important medical concepts? Have we captured them? Have we incorporated as best we can, given the information we have, into the code? And can we justify that on review and audit? And if the answer is yes, I've never seen anyone go to jail for accidental fraud. Most fraud is pretty bad, right, before people go to jail. But everyone worries about that. If I don't use the right word, no, that really is not the way it happens. And I've been looking at fraud cases for a very, very long time, and I can tell you, most of these people, you would want them to go to jail because most of them are criminals. Right? Matter of fact, we don't catch billions of dollars worth of people who are just pure criminals. So I wouldn't worry about that. And you just stay focused on the one thing. What are the key medical concepts? What's important in risk, severity, and complexity? Have I captured those concepts, and do my codes reflect that as accurately as I can? Where you do get into trouble, and I've known of people who've gone to jail over this, is if you start doing creative billing saying, well, this code doesn't quite pay, right, so we're going to use this. Or you start fudging. Right? And I got into that trouble in my own hospital where they wanted me to code all of my total hips with post-operative hemorrhage. They told me, well, they did bleed, didn't they? Right. And I said, well, yeah, that's normal. And they only bled, and I gave them back all their own blood. I didn't give them any other blood, and it was exactly what I anticipated, so don't put hemorrhage on my chart. I refused to sign the chart. Oh, that caused all sorts of issues. Well, you don't understand how we code and reimbursement. I said, I understand what the truth is, and this is not the truth. Now, it turns out that hospital really got dinged because they had a very high complication rate after total joints. So it came back and bit them. Right? The key is stick to reality, stick to what it is, and you stay out of trouble. Once you start getting creative with this pays and that doesn't, that becomes where it gets risky. So. Yes?
Is it the first time that particular provider has seen that problem?
Right. So good question, and actually we're going to talk about this afternoon a little bit, is the use of initial and subsequent encounter. Right? The basic rule is, if it's the first time that that physician has seen that patient for that condition and they are independently evaluating that, that's an initial encounter. ER doc is an initial encounter. For the orthopedist, if, however, you go on vacation and your partner sees your patient for you, because it's a new doc does not make it a new initial encounter. Right? So those are very gross guidelines, but it's not really rocket science. You just have to, it's not really different than what we do for CBTs.
So I think one of the elephants in the room is cherry picking of patients because we don't have good risk tools. And to talk about your total hip patient, for example, there are doctors who won't do a BMI over 40 now. And there are many other ways of avoiding adverse patients, such as low pain, high risk patients who make bad decisions on a regular basis, regardless of how much education they're given. So what is there any reassurance about this?
Well, I'd like to say there's a reassurance about any of this stuff, and I can't give you any reassurance because then I would have to assume people do things logically and rationally.
The question.
The question was, sorry about that, the question was, you know, how do we really adjust for risk and you know, are we really going to get a fair shake in adjusting for risk and complexity and severity? I think that was sort of the gist of the question. And the answer is, we don't know. Right? Again, payers aren't very clinically minded. But we do know that people are actively looking at everything they can to identify risk, severity, and complexity. And sometimes they don't know what to look for, and sometimes they don't know what the key parameters are. So I've always found that if you're going to be talking about risk adjustment, they're going to be talking about payment adjustments and capitation, I want to be at that table to make sure that they recognize true risk issues. I think BMI for all total hip patients, I would have it on my template, because when it comes back and they look at you and say, we looked at this data and you have a very high complication rate, we'll say, well, let me show you the risk factors. Even if no one else has those risk factors, you do. Right? You have a good description of why you have those complications versus why you have a higher level of complications. So I think capturing those is important. BMI, smoking history, anything that might relate to the risk, severity, and complexity of that case, I would try and capture it. Now, you can go crazy about that. We'll talk a little bit about what you don't capture, but yeah, I would try and, anything that relates to that, I would try and capture. Other questions? Yes?
So you talk about BMI as a risk factor.
Right. Yeah. I would draw the line at capturing anything that would make a difference, and how I would determine that patient's risk, severity, or complexity, or that I might make a different decision on how to manage them or how to monitor them.
What I'm getting at is coding should be incredibly arduous.
It can be.
They all have, depending on different clinicians, they determine how much effect they have on your outcome and everything else.
Right. It's your judgment, right? No one says you got to use X number of codes. It really comes down, do you think that this code would make a difference in how that data was analyzed to determine risk, severity, and complexity? And if you think it's important, I would include it. If you don't think it's important, there's no rule that says you have to include everything. How are you going to get consistency? Well, hopefully it's the same way you get consistency on everything else. I mean, you know, you make a judgment in terms of what. Yeah, the people who do it are going to be better adjusted than the people who don't. But no one's going to do it the same. I'm sure of that. Yeah. No, they're not, but it's evolving. The payers rely on a number of different organizations for risk adjustment models, and those risk adjustment models are constantly being looked at and evaluated based off of historical data. If we don't get it in the historical data, it won't be used in risk adjustment. If it's in the historical data, then these, which are done by a lot smarter people than payers, right? Hopkins and a bunch of others, that are building these risk adjustment models, and you're part of that risk adjustment model development, then it will be counted in. But it won't be if we don't have the data to factor that in. That's why I'm saying, starting right away, you want to try and capture this stuff because it's going to be important to look at the data. And you may not see it right away, but ultimately it's going to factor into those risk models. Other questions? Is it lunchtime?
Thank you very much.